Attendees are in listen-only mode.
Well, hello and welcome to this month's HIPAA Chat. Today we're going to be talking about meaningful use final rules, HIPAA, and more. Thanks for joining us on your Friday. I'm Carol Fly with High Tech Answers, and as you're regular here on HIPAA Chat, you know that EFAC's corporate sponsors HIPAA Chat. Without them, we couldn't have this program, and we're glad to have them on board. HIPAA Chat is now on LinkedIn. Please check out the link, join the group here, and we've got active discussions going on there and all of that. So check out LinkedIn if you're on LinkedIn and join our group. Of course, HIPAA Chat is hosted by our expert Steve Spearman. Got several decades in health IT space, and he is the guy that we go to for our HIPAA questions, and we know you do too. Obviously, you can contact him. He takes questions from anybody at Spearman at healthsecuritysolutions.com. And he's got a new video conference schedule for you to check out as well. Free videos, teachable moments at healthsecuritysolutionsteachable.com. Our guest.
Yeah, let me make a quick let me make a couple of quick comments. First of all, thank God for for photo editors. I'm just going to say, I'm just looking at my phone here. I'm just, I'm not suggesting it's been, edited, but
I've met you in person. It's a reasonable facsimile.
Okay, yeah, no shiny forehead though. So, but I will tell you, I've got on my new conferencing site, I have got a my Security Essentials, which a lot of people have listened to over the years. It's now available as a free, listen to it anytime call there. It basically, and I've even referenced it some in this call because on HIPAA Chat, because we can't always go into the particulars of the security rules, and it's just a great presentation. I may end up referencing it again today, and now you can do it at your convenience anytime at no cost at Teachable. And I'm also going to mention that we are going to be standing up a paid training for staff.
Oh, that's right.
Well, over sometime, probably within the next few days. We're almost done with the editing. So check it out. Yeah, we'd love to see if that's helpful to some folks.
Yeah, and that link, healthsecuritysolutions.teachable.com, is the one you want to go to check out his free video conferencing, and so give that a gander. And before I introduce Beth, Steve and I were talking, it's like this 1960s TV crossover, when Superman goes to visit Batman and Robin. We sort of have that version today because Beth is one of our experts on the ABCs of MIPs, which is another webinar, our monthly webinar series covering MIPS, and she's on today's show. So we have like a 1960s TV crossover. Yeah.
I love it.
I gotta say, Carol, this is not 1960s. I mean, I watched an episode of The Flash this week in which the Arrow showed up on The Flash's show.
Okay, I have no idea what you're talking about.
Yeah, those are DC superheroes, which, because they're DC, you probably never heard of them. But anyway, yeah. But I think that means, Beth, that you're supposed to have me on your show at some time. But I'm not sure I would be very useful there. But maybe color commentary. I don't know. Welcome to my program. Welcome to my program.
Thanks for having me, and so I too am appreciative of the photo editors that are out there. But since you haven't met me in person, you can also imagine me like this.
Steve, I've met Beth a number of times. She looks exactly like that. And of course, what we're referencing, the show that Beth is an expert on, is the ABCs of MIPS. The third Thursday of each month, we have the ABCs of MIPS, and then we have HIPAA Chat on Friday. So if you're new to HIPAA Chat, you can check out ABCs of MIPS at healthitanswers.net and our event calendar. And so we're very excited to have this convergence of forces. Yeah. Mm-hmm.
Hey Beth, now, and please understand, I totally understand all this. I'm asking this question on behalf of our listeners, right? I mean, I totally get it. I could answer this question. Still, why don't you go ahead and just really quickly describe what MIPS is?
Okay, so you know what, I will also in doing so also reference our website. So my company is saignite.com, and we have 10 FAQs about the merit-based incentive program called MIPS. So, you know, I think at some point the people realized that they could no longer in the government rely on the SGR reimbursement formula and keep kind of going back to Congress and you know, adjusting things. So that is being replaced with something I think people are going to be cheering about in relation to, you know, the reimbursement program, which is this MIPS program. So MIPS is consolidating a bunch of other programs, including Meaningful Use, and creating a 100-point scale score for physicians that will then be reported out.
So it's the future of healthcare from a Medicare payment standpoint.
And from a monitoring and pay-for-performance standpoint.
Okay.
So people
quality and okay.
And
exactly.
And interestingly enough, is a player in the final rules. We have a couple quick slides on this before we dive into questions from the registrants, and of course we'll take some questions from our audience as well. But certainly there are MIPS implications on the EP side, and so I think Beth, you were going to just give us a 30,000 feet up on a couple of bullet points before we start taking our questions.
Sure thing. So I think you're just, you know, I guess I could summarize the modified stage 2 rule in 2 words, simplification and stability. And I'm going to emphasize that stability point in a second. So from a simplification standpoint, I think they recognize that it's really hard to keep monitoring who's in stage 1 and who's in stage 2. So they're calling this the modified stage 2, and really everybody is in modified stage 2 going forward. Those people that would have been in stage 1 get some specific exclusions for measures, but going forward, everybody's really in the same stage at the same time. And working with really large practices, I know that there's some people pretty excited about that. They also simplified it quite a bit into only 10 objectives, and they have given the specific go-ahead on just the 90-day period for 2015.
And so, there's nothing like a menu set like before. It's like 10. There's 10, and you do have to do all 10, right?
Yeah, exactly. No core and menu, so no
choices, no figure out.
No choices. Mm-hmm. And really, I think for a lot of these organizations that are working with providers and trying to get them to meet the measures, you know, if it's a moving target, you know, like, well, you're not quite meeting this menu measure, so let's flip over and try this one instead. That's confusing. So so I think that's also something that everybody embraced. And I also would say, and there's a lot more stability, I think, in this. So I hope that we don't have another modified rule in the next 2 years.
Oh my gosh, yeah, right.
So yeah. So we have, you know, obviously everybody's been in limbo mostly in 2014, and then we've been in limbo in 2015, and now they're saying that the 2014 certified edition is valid through 2017. So with this announcement and the simplification, I hope that that is a signal that we are going to be nice and stable for at least 2 years.
Beth, one thing I learned from this was I was at HIMSS back at, when was HIMSS, Carol? Like end of March?
It was actually in April because it was in Chicago and it was super cold.
Yeah. And when we were there, I think we both, you know, went to pretty much all the CMS sessions there, and they were very emphatic that the final rules would drop by August 1st. And I've been telling clients and others that, okay, August 1st, but we got all the way through August and September and still nothing. So I think
and I think part of that issue, and Beth, correct me if I'm wrong. I think part of the issue is, you know, they released the NPRMs for you know, modifying stage 2 and stage 3, and then MACRA was passed.
True.
you know, I think on April 16th, after, I mean, like days after, you know, they release the NPRMs. And I think that passing that bill sort of, you know,
threw them for a loop.
Well, I think because it does consolidate MU into the MIPS program starting in 2018, and I might get, you know, I could be wrong about that, but it just seems like the timing, you know, might have impacted. Yeah.
Well, that would explain it.
Yeah.
So I just thought it was typical bureaucracy, you know, government bureaucracy. Glad you're, you know, yeah.
Either that, there was lots of lobbying up there to delay. You know. Who knows? I mean, maybe they wanted people to get through, you know, providers to get through the ICD-10 deadline. I mean, you know, ours is not.
Yeah, that's a good point.
Ours is not to, you know, we might be superheroes, but ours is not to question why.
That's right. Yeah.
By the way, for the benefit of our listening audience, I am an Avengers girl. I like the Marvel. Okay.
Yeah, of course. Like Marvel versus DC, this is like, are we even debating this anymore? You know, so yes, I mean,
hello,
they're
Thor.
trying. They're trying.
Just one word, Thor. That's all I have to say. Okay, so we're gonna dive right in. We're gonna start with questions that we got from our registrants. And of course, during the broadcast, if we don't get to your question, I have Steve and Beth's email available, spearman@healthsecuritysolutions.com and beth@saignite.com. So if we don't get to your question or you need further clarification, please shoot them an email before, during, and after the broadcast. Just to remind everybody that you will be getting a link to the YouTube video for today's broadcast. All right. Diving right in.
And it's worth pointing out to everybody that we also post questions sometimes that we don't cover here on the LinkedIn HIPAA Chat group. Which is So and I'll tend to get anywhere from 4 to 6 you know, emails after HIPAA Chat where people are asking me, you know, questions, and everybody will tell you I respond to those emails and try to be as helpful as I can be. So
he does. Okay.
Yeah, don't hesitate to contact.
Okay. All right. You guys ready?
Yes.
Okay.
Sure thing.
First question. Are these guidelines to questions one could expect to see or hear during an actual audit? And I'm actually not sure when we talk about these guidelines whether we're talking HIPAA guidelines or MU guidelines, but I'm assuming they mean MU.
Yeah. Now, and then so what? And you're talking about guidelines? Are they talking about rules or whatever?
I mean, final rules, right?
Yeah. So, I guess my answer to that question is that it's safe to say that the final rulemaking will be incorporated into the audit, the meaningful use audit program. As many of you may or may not know, that program is being administered by an accounting firm in upstate New York called Figliozzi and Company. Figliozzi,
they are the audit contractor for CMS.
Yeah. What I will say too, that Jim Tate and I have both been very kind of, I think, a little bit on the forefront of issues around that program, and I published some data last year that I got through a Freedom of Information Act request around that about the program. And the most interesting thing to observe now, since I have people, I hear from a lot of people, is that they have heavily moved to prepayment audits. So whereas before you had to endure the humiliation of potentially returning money, my experience is that most people are getting audits that are prepayment audits, and so which you may not get the money, but you don't have to return money that you may have already spent. And now they are doing some post-payment audits, but other than that, I mean, I think it's safe to say that, I mean, they're going to have to change. You know, they're going to the going forward for this. For 2015, when they do audits, it's going to have to reflect the standards for 2015. So you expect to see that. Beth, what do you? I mean, it's a little bit of a vague question, but what do you think?
Yeah, you know, I think I kind of agree with you. I mean, at least from an anecdotal standpoint, it certainly seems that there were a lot more prepayment audits with our customer base. But for the first time, I've seen somebody get audited for the 2011 payment year. And I think what it underscored, at least in this situation, but it's kind of broader than that, is how much you don't remember what you did in 2011 and what the rules were at that time. And with all of these changing rules, I think it is really, really that much more important to both document thoroughly your audit materials, but also what rules those were being related to.
And I believe CMS can audit for 6 years, can't they? They can go back and audit for 6 years.
Yeah.
6 years. Yep.
Yeah, and as Jim Tate has said, and I've said, and others, it's like, I strongly recommend do not wait until you get an audit letter to start producing the supporting documentation. As you're attesting, have a folder that's, call it supporting documentation or what you will, that addresses each of the measures and that proves compliance against the measure.
I think Jim calls it creating your book of evidence. Yeah.
Yes. Yeah. And I'm going to add one more thing here is there's an awful lot of people switching EHRs.
Mm-hmm.
So making sure you're doing that, because you won't be able to go back in the EHR and pull down the log that says that the clinical decision support rule was enabled for these physicians. Since you won't be able to do that, it's even underscores it even more.
Yeah. In defining jurisdiction for health registries, not knowing if a registry exists and claiming exclusions. So,
I do. I too had this question. So one of the what the rule is for public health is that you have to, if you're a stage 2 provider, you need to attest that you've sent or you have active engagement with 2 public health registries.
Not 3, but 2. Okay.
Not 3, but 2. And 2, those 2 can be any combination of public health registries as well as specialized registries, so just to be clear. So what they also say, though, is that you can take an exclusion if, according to the exclusion criteria, that there are no other, that no registries exist. So the problem is, and I think this is where this questioner is going, is you don't know how many specialized registries are out there. And so it's kind of like, can I take an exclusion or can I not take the exclusion, because I don't really know the full list. So I found this. It says jurisdiction is defined as a registry that is administered by or on behalf of a local, state, territorial, or national public health agency. So they specifically define the jurisdiction to be those that are administered basically on behalf of or by the government. So there's a number of different specialized registries that are outside of that, and those can count towards your specialized registry. I think they use the example of the prescription drug monitoring program. It'll count, but from an exclusion standpoint, that's how jurisdiction is defined.
You just knocked out 3 questions right there.
I hope everybody followed that.
Hey Beth, I hope you can sing well, because you're going to just have to, extemporaneously sing for us, if we run out of ideas. Actually, let me ask you a question, Beth. I had a client earlier this year. They were a specialist. They were specialty. And so the issue of the registry came up. I can't remember. I think they were maybe an ENT registry, and so I had to do some research for them and found out that in fact the academy governing whatever that specialty was has a registry that you could be a part of, but they had to pay for it. It was like, I think, a couple of grand a year, and since most of my work isn't specifically around meaningful use, I just gave them a little direction and said, go to your, the academy, whatever, and see. But that was actually that was a case where, there was a registry available. They had to pay for it. Did that allow them to claim an exclusion? Yeah, it was. I didn't really with them for that. So.
Super interesting, and I think there's going to be lots more of those edge cases too. I'm hoping that jurisdiction description holds up and people can kind of point to that in when they claim those exclusions.
Yeah.
Okay.
Yeah.
All right. So we're going to, again, these are the questions from the registrants in no particular order, but we actually had two of them came in at the same time regarding security risk analysis, SRA. First, are we, for MU, are we required to conduct a full SRA every year? And second, have the requirements of SRA changed with the newly released final rules?
Okay. So let me kind of take these on. So the answer the answer to the first question is no. You do not have to conduct a full risk analysis every year. And let me actually kind of point out something, and that is, and we're going to get to this in a minute, I think, because is that really, you know, definitely there's a little bit of some change, and I'll get to that in a second. But you know, we're in its initial version, it is clear that that their intention was a HIPAA risk analysis.
Mm-hmm.
You know, there's some confusion now with the rulemaking that just was finalized, and I'll get to that in a second. And so based on both HIPAA and information security best practices, you would need, so based on HIPAA and information best practices, which actually doesn't say annual. That's one thing people find interesting, is that, you know, does HIPAA say I have to do this annually? And my answer is no, it doesn't. You should follow your policies, and your policies should conform with best practice, which is, best practice would be either some sort of full risk analysis or review every year. So, but meaningful use makes explicit what is not explicit in HIPAA itself. And when people ask me what you should do, I have this trick answer I always say. I say you should do what your policies tell you, because policies are what dictate compliance means. And so, you know, and if your policy says you do, you know, risk analysis every 10 years, let's say you don't care about meaningful use for whatever reason, that's a really bad policy that will get you in trouble. You need a policy that, you know, follows the guidelines for best practice, that's mapped to the regulations. But meaningful use makes it explicit. You have to do it something every year. Now, both the accepted practice and the language of HIPAA would allow not necessarily a full risk analysis every year. And you can do, I actually do for many of my clients what's called a review or update. And that process is really more iterative, where we're looking and saying, hey, we did a risk analysis for you last year. What's changed in your environment? What new assets do you have? Have you had any incidents that need to be reflected in your security management plan, and update that? So, so I would recommend that people do a minimum of a full risk analysis every 2 to 3 years, and a review or update in the intervening years, and that, you know, that appropriately addresses changes in the environment. But if you have a significant change in your operating environment, such as you go to a new system, like with Beth saying you're going to a new EHR, you need to do a new full risk analysis, because there are a whole different set of risks that are going to accompany that change. Now, the thing that was interesting, it's a long answer, but it's kind of complicated. The thing that's been interesting is that the language under this most recent rulemaking actually does appear somewhat to change the scope, even though even in the comments to the rulemaking, they kind of deny it. They say a commenter stated that the scope of the risk analysis in the proposal appears to be limited to EPHI created or maintained. You know, suggested that the scope is more limited, and their response is that not really. I mean, they seem to like deny that, but it seems the language itself is different, and so I don't know what they were getting at with that. It's kind of an interesting take. There is one other thing that was in the rulemaking. It's not in the actual language, you know, of the final rules, but it's in the rulemaking. It's in the comments. And there was this very interesting, and I've seen a couple of articles about this. There's this very interesting kind of way that they're positioning the risk analysis, as they're saying it shouldn't be seen as, quote, episodic or quote not a quote snapshot. And
Okay.
I got to tell you, as a guy who, this is what I do, it is very weird because, first of all, they say it should cover the entire year of the reporting period, but yet you can do your risk analysis at any time. So one of the questions I would have for somebody is like, let's say you do your risk analysis in June, which you're allowed to do for a for mid-year 90-day reporting period, and you do that. How can you assess the risk for the future? That is pretty clearly in the comments, and I have always told my clients that the proper way to think about a risk analysis is as a snapshot, and that the security management plan, which is another HIPAA requirement, is the thing that is responsive to ongoing issues. You might even, quote, update a risk analysis as opposed to an issue. So that was one thing, and I've seen a couple things that I've seen a couple of articles that kind of, and honestly, I'm really dying to see what their guidance is on this because it's kind of confusing. And so, when we do risk analysis, it has a date on it. It has June 18th. That date ideally is within the reporting period. Now with some of the changes on the timing, it could be any time during the calendar year. So anyway, there are kind of some interesting tweaks with that. But let me emphasize to everybody, you need to do your risk analysis by December 31st of this year. So make sure you get it done.
And let me just add one thing, because I know what question customers ask us all the time, which is the timing for it. So it needs to be completed prior to the date of attestation. So that's why December 31st works.
Well, let me actually say the problem, let me say one thing is that, but in this calendar year, it has to be done by December 31st. In other words, if the language is such that if somebody, let's say their reporting period is the last quarter of this year, and then they do their risk analysis on January 15th, that is actually not compliant under the rules.
Correct.
Even though they're testing, it has to be done during the calendar year of the reporting period.
Yes, I noted that same thing. Yeah, because it really means so they're not going to give you that credit for that December 31st
reporting. Yeah, exactly.
Risk.
It used to be cleaner. I mean, Carol's seen me go through the changes that were forced by the FAQ they published last year, because it used to be very clear that it had to be done during the reporting period, and then they changed it. Okay, during the calendar year, as long as it's done prior to a testing.
Right.
And actually, that was kind of one of the justifications. That thing I was just telling you about around the not a snapshot, it was kind of their reasoning behind allowing it during the calendar year. But again, that in and of itself is confusing to me. So we'll see. But just put it out there, black and white. Got to do it by the end of the year. So do your risk analysis by the end of the year.
You just checked off another question from the registrant, one of the registrants. Real quick, somebody listening in right now. Great question, I think, for Beth. Will MIPS replace MU for hospitals also?
Ooh, great question, and I don't know the answer to it. I don't know the answer. I'm sorry.
Yeah. I think that, I think it's important to understand that MIPS is still in the rulemaking stage.
Yes, yeah.
It is still in the rulemaking stage. So MIPS from a penalty standpoint starts in 2019. So the penalties will start in 2019 and replace the penalties. That's when MU will top out, would be in 2018. However, what they haven't yet defined is what the performance year would be. So we think, just because it's historical, it's been a 2-year lag, we think that the performance year would be 2017. So your performance on meaningful use in 2017 will impact your MIP score in 2019.
And that's for EPs under the Medicare side. We still haven't.
Correct.
Yeah, they haven't even addressed yet the eligible professionals under the Medicaid side, or I think the hospital. So I think that, and that may all unfold with the rulemaking, which I think they're talking about coming out by spring of 2016. I think will the final rule. So.
That's what I read too.
Yeah, me too.
You know,
yeah. Mm-hmm. Amy, question, going forward, or even in stage 2 or stage 3, when they talk about the 90-day period, can it be any 90-day period, or does it have to be a calendar quarter?
Nope, it can be any 90-day period, rolling 90 days. So lots, 275, right?
Yeah, exactly.
275 different periods.
That's a lot.
It definitely is. And I think they're...
Yeah, because you would assume it's calendar quarter, but no.
And it was calendar quarter. It was calendar quarter in 2014, but yeah, it's any 90-day rolling period. So it has to be contiguous, of course. I mean, not to state the obvious, it has to be a contiguous 90-day period. So, Hey, Carol, did you get the question from Janet? I got an email.
Did you email me? You emailed me a question?
Yeah, I think I did. Yeah, I did. Anyway,
what you want to read it?
Yeah. Okay. Yeah, I just don't do it as good as you, though.
Oh, I see it. Yeah. So yeah. Well, first of all, shout out to Janet. Thank you for emailing a question on the fly.
Yeah. The way you tee those up, Carol, I just never pick her up. Okay.
I love the golfing reference. All right, so here we go. So for 2015, which measures can be met outside the reporting period? For example, health information exchange. Can we send the CCD right before we attest next year for the 10%?
That is correct. You are able to do that outside of the period. And you might want to confirm with your vendor that is the way that that it's being counted in your reports.
Right. Thank you, Janet. It's still a little confusion here. Can we jump back to the risk analysis for the timing? Actually, the timing of the risk analysis. Somebody chatted in, if you complete the risk analysis in November 2015, can you report for meaningful use from August to October and still be compliant? So we're still getting some more questions about the timing. So
you actually can. I thought that surprised me because in the past I would say that wouldn't have counted.
Yeah, that changed it really effectively with the FAQ that CMS published last November. And so, yes, the risk analysis date can be after the reporting period as long as it's in the same calendar year of the reporting period.
Right. Okay, all right. One more follow-up question on SRA. You were talking about in the modified and the new final rule. One of our listeners wants to know, what sort of language do you think the auditors will be focusing in on? I mean, is it
on the SRA?
SRA, is it going to be, dealing with EPHI? Is it going to be, is it going to be encryption?
Okay,
I mean, that's great, yeah.
Yeah, and I kind of touched on this, but it's a good question that allows me to. So in the new rulemaking, they seem to limit the focus of the risk analysis, which is a very clear change over the past, but to the EPHI, contained, created, processed, transmitted within the certified electronic health record. So my answer is, you need to be able to demonstrate that you've documented those risks. The language of HIPAA, which is pointed to in the meaningful use rules, says you have to document the, quote, threats and vulnerabilities to the confidentiality, integrity, and availability of electronic protected health information. And my real kind of response to that is that at the margins, we're not talking about a lot more work to do a complete HIPAA compliant risk analysis. A complete HIPAA risk analysis would involve documenting all the assets that contain, process, manage, transmit protected health information, copy machines and mobile phones and things like that. And I think adding, extending out the scope to include those is, I think it's fairly trivial for most organizations, and in fact has the advantage of I think it provides a clearer line of demarcation for people that have to do this. So and also keep in mind the specter of random OCR audits that are going to begin in January. They just announced that. These are HIPAA audits. They're going to be both desk audits, and again, theoretically, you could do one that's compliant with meaningful use, but that you would fail during an OCR audit. So, hey, why don't we just do these together and get it done? It is one change in the rulemaking that I think was, I don't know why they did that. To me, it makes it clear. So, but technically, under the rules, the scope is more limited. Under this rulemaking, it's limited to the CEHR.
All right. So let's move into a couple questions in sort of the realm of health information exchange. So somebody wants to know, what are the requirements now for health information exchange between providers to meet meaningful use? Or presumably meaningful use in either stage 2 and or stage 3.
So they've now consolidated, really, summary of care. That's the one they used to call it, the summary of care measure, under a single objective called health information exchange. So what they say is that the EP that transitions or refers their patient to another setting has to use the certified technology to create a summary of care. And electronically transmit that summary to a receiving provider, okay? And they only have to do that for those % of those that are transitioning. So there is an exclusion if you refer less than 100 times during the EHR reporting period. What they changed on this one is both the exclusion as well as the ability to send it multiple ways. So it was very specific before about which ways you could send the information, and now they're just saying that you need to create the summary of care record and electronically transmit it, but they're not being specific about submitting it through an HIE or doing anything like that.
So somebody actually in the registration process asked sort of I would guess call it more of a philosophical question, and since we're talking about HIE, health information exchange, I might as well address it right now, which is how much interoperability will we really achieve, and probably related more to stage 3 requirements, but
yeah.
Now, Beth, hey, Beth.
Go ahead.
This is Steve. Now, again, I totally get this. It's completely within my, domain of expertise, and I totally get it. Just for the sake of the audience, members that might be listening, would you explain what interoperability is?
Right. But I'm going to pass it back to
you. Nice. Well, from a security standpoint, you should definitely worry about interoperability.
Oh, I do, and I do have a segue that you're going to like, but yes, go ahead.
Of course, what it means is transfer of information back and forth. So things are, the summary of care that we just talked about would be a good example of interoperability. So I think, philosophically, I don't think that we've achieved that, but what I hear from our clients, and this is kind of sort of number one, is still really hard for them to meet certain measures because they don't have the ability to receive. So even if your EHR has the ability to send, it's hard to find the right organization that has the ability to receive. So I think some of the long-term care facilities and so LTACs and other settings that have been a little slower to adopt electronic health record systems have not been able to do that, and therefore make it very difficult to meet this measure.
I mean, so
we're not there yet.
I think there've been some mismatched incentives, because some of these groups that are supposed to receive it haven't had the incentives that were provided under HITECH to basically do this. So they it's like they had, where do we send it? How does interoperability like connect with the, is the patient portal related to that at all, or is that a different, I mean, I know that's patient engagement, but are they kind of under the same category?
You know, Steve, I got to be honest, I would say yes, but it's more based on kind of, I would broaden the different definition of what interoperability means. I bet they're talking system to system when they talk about it. But
certified.
But
yeah. Mm-hmm.
So
let me.
Yeah. So go ahead.
No, I was going to say I'd like to hear, maybe you want to talk a little bit about the changes in the rulemaking on the patient portal requirement, which I think most people have applauded. A few, were upset about it. But the other thing, I'll go ahead, before you do that, I'd like to just say that when you guys are doing your risk analysis, you really need to look at the risks associated with your patient portal. We have done work where we have, looked at and the reason is those are almost always web-based portals, and they present a certain kind of thing. Is I would encourage everybody to make sure that they're including the portal as a part of the of their risk assessment. And having said that, though, do you want to talk a little bit about the changes in the rulemaking about the portal?
Sure. In general, I think the people that said they're not excited about the reduction are those organizations that represent, patient-doctor relationships and really are trying to advance patient engagement. And if you know a bit about those, I can't say that I disagree. So you want incentives in your doctor's office to make sure that they're communicating with you. But they did lower it quite a bit. So
they did. A lot.
The view, download, transmit in 2015 is only one patient. So you just have to have one patient that views, downloads, or transmits their information. They kept that the same in 2016. In 2017, it does increase to 5%, which is still lower than what they require right now. But, and this is the big but, in 2018, for stage 3, it's at 25%. So you have a pretty big jump there. I think overall there was a theme in this rule to talk about a little bit more about kind of transitions and making things, kind of have more of a ladder towards the next stage as opposed to things being abrupt. So this is in that vein. I would say that I'm not sure that the ladder has the right angle to it, and people are going to be maybe still struggling to meet this. The secure messaging part of the measure, they again lowered it completely. So in 2015, you just have to say that the capability was fully enabled, so that patients are able to have that communication back and forth. In 2016, it's one patient, and then it's similar in 2017 and 18. It's 5%, and then 35% of the patients need to do that. So.
Now, how would, for 2015, just to be able to demonstrate that you've enabled it, how would you recommend somebody document that?
That's honestly, I really would document it by seeing whether or not you can get one patient. So, because the EHRs are reporting it, and they're reporting it now, obviously, until they change their reports, I would see if you get one patient, that's the most foolproof. But of course, you can go down the path of, documenting that. Exactly. Yep.
Yeah.
Well, that's it, and actually sort of segues into one of the questions from our audience, which is, this relates back to MU audits, but it's a documentation, which is, what is the best way to document exemptions from measures to survive an MU audit, or really just in creating your book of evidence? I mean, is it screenshots? Is it reports? I mean,
book of it's a good point. In a way, it's in some ways, documenting exceptions is tricky because it's sort of like proving a negative in a way. It's like,
yes.
so that's a great question.
You know,
which of course I know the answer to, but I'm going to leave that one to you too.
Well, I'm going to let you be more specific on the documentation, and I'm going to get sort of evangelical for a second about how important it is to document and talk again about time, you know, and the fact that you can be audited up to 6 years. So I have a real specific example of one that I thought of, and it kind of relates to that public health conversation that we had at the beginning of the show. So one of the, if the exclusion is that you can take an exception, an exclusion, if there are no registries that were relevant to you, you need to find a way to list the number of registries that are relevant as of today. And there is no national database of those, so you have to find a way, again, it's proving the negative, to show that these are the registries that exist, and then the connection point, which is that it is not relevant, says that you do not diagnose or treat any condition that is required by the registry. So let's say that this is somebody who changes the scope of their practice at some point. You need to also find a way to describe, you know, probably via the reports, what conditions are treated currently. So again, point in time, because if you even wait a year, it's going to change.
I'm going to kind of circle back or go back to HIE, for example, Health Information Exchange. One of the listeners today wants to know, would the exclusion for summary of care for HIE measure for providers who transition less than 100 patients during the EHR reporting period? Since the reporting,
good question.
Yeah, since the reporting period is 90 days, does that mean you get to exclude if you transfer less than 100 patients in that 90-day reporting period?
Correct. And it's actually 100 times. So if you have frequent flyers, a patient would count twice.
Oh, they double.
Yes.
So it's sort of like more. It's like not patients. It's more like transactions.
Transactions.
Yeah. Exactly. It's transfers.
Oh, okay. Transfer. So it could be the same patient transferred 5 times.
It could be. Let's hope for everybody's sake there's not a lot of those.
There's not a lot out there.
So that's right.
So one of the attendees chatted in. This kind of makes me chuckle a little bit. Can you get together with another provider and just send some records back and forth to just reach compliance? It's kind of diabolically kind of interesting question. Yeah.
I'd like to see the proof documentation. It's a Starbucks video camera feed that's saying, here you see me sliding the records over across the table. So, yeah.
Yeah, I think if under documenting your book of evidence, that would probably raise some eyebrows. Yeah. And can you clarify if the interoperability requirement of providers with an enterprise system, are the summary of care HIE counted in the denominator or excluded? So that's a if that person could just email me and Beth and Steve offline so we can get more clarification on the question, that would be great. And we'll try to figure that out.
They're stumping the hosts here. I think they're trying to stump the hosts.
Well, it's interoperability. Speaking of interoperability and a plug, but this interoperability issue is sort of like one of the great challenges of the whole meaningful use process, is to get to interoperability, just from that higher level up, that this idea that you can actually seamlessly, like a banking system, exchange a one patient record from one certified EHR into another. And it is some state HIEs have been able to do this, and some vendors partnering together, like an ambulatory vendor partnering with a clinical hospital system have been able to achieve this, level of interoperability, certainly from a testing standpoint. But actually next Tuesday on the 22nd, High Tech Answers, we're actually hosting an interoperability panel discussion moderated by Justin Barnes, and we've got, four national thought leaders on this event, literally talking about this issue. Back to the question from the audience, what does this mean about achieving true interoperability, through the various stages of meaningful use. And so, check that out. If you go to High Tech Answers, we did a post about that event today, and you can register for it. It's free, of course. So it is a big question. Obviously, there are some requirements related to it from probably what are baby steps, but interoperability is certainly the key topic.
There's been some interest. Yeah, there's been some interesting. I call it infighting maybe or whatever, but a couple of years ago, a few of the major hospital information system vendors, McKesson and Cerner or whatever, created an association, kind of committed to interoperability, and then Epic said, "We're not playing in your playground," and then they. I think less than a year later formed their own kind of to establish standards. Because obviously in the what they have this vision for universal interoperability, regardless of electronic health record and geography or whatever. I don't know if we'll ever get there, but that's kind of where they want to go. And it's safe to say it's not going to happen without standards. Somebody, and of course those have been somewhat developed through the direct messaging protocol and other things like that. But
yeah, and I think FHIR is the one. Somebody chatted in other standards. We've got people chiming in on this conversation that we're having about interoperability and HIE, and does HL7 have to be used? HL7 has developed FHIR, and I know it as the acronym FHIR. Like if you Google FHIR, you'll get the acronym. And there's been a big push for FHIR at a number of different levels as a standard for developers to work on. There are a few people who say we need a national patient identification system that would solve the interoperability challenge. But yeah, there's
a lot of stuff to figure out that I think is over your and my pay grade, Carol. I think I'm not sure.
Yeah. It's like I know the acronym FHIR. If you want to get an idea of the current situation with standards, and again, standards are you have to have standardized fields and code to appropriately exchange these files. But if you Google FHIR, you'll come up with, or go to HL7 website, and you'll get plenty of information about that. We've got time for a couple more questions. Sort of a basic question. One of our attendees wanted to know, can you actually define what PHI is? I think that we all kind of maybe take that for granted, but yeah. Personal.
So, yeah. And actually, the shameless plug here that HIPAA training for staff that we're standing up at the Teachable Health Security Solutions.teachable. We actually have a slide. I don't have it handy, but there are basically 18 specific things in the regulations that define what protected health information, and everything from medical record number. PHI is individually identifiable health information. So a name by itself is not PHI, but with any kind of clinical artifact. Even for example, John Smith is not PHI, but John Smith has an appointment with Dr. Jones at 2 o'clock. That's PHI because it's an appointment with a physician of a certain type. And so once you add an identifier like that to any kind of clinical artifact, then it becomes protected health information. And it is, if you are a covered entity, then it's governed by the HIPAA privacy and security regulations, and you have to properly secure secure that information and ensure its confidentiality, integrity, and availability. So those you could. So if you wanted a Google term, put HIPAA patient identifiers, and I believe it's 18, and you put 18, and you'll probably go to my website because I've had a blog post about that, and so.
There you go. I'm going to take one last question, and for Beth, it really got a couple people sort of chiming in on this registry issue and specialty registry. Mm-hmm. Reporting is technically a new requirement for hospitals. Where do we start?
Oh gosh, that is a great question. And
I will tell you, Beth at saignite.com.
Truly, feel free to email me. I'll tell you, I dug into the public health rule the most, I think, when I got the rule. I believe in the where should I start, I would absolutely contact your state extension center if your state still has one, so your regional extension center would be a good place to start. And from that point forward, I email me and I will have an answer for you.
I mean, I'd like to think that HIMSS will come up with some resources that can help address these questions. And in Chica, is it in Chica? They're going to be.
You're talking about ENAC?
Well, ENAC, yeah, ENAC, and what about WEDI? I don't know, or what? Do you know? I mean, so.
Yeah, yeah, they're in the interoperable. Yeah, I mean, I would ENAC.org. They actually do certification in the health information exchange space and other things, but they're not a certifying body like a certifying body that certifies certified technology for EHR, but their website is ehnac.org, ENAC, yeah.
So this doesn't help you for 2015, but it is in the rule to create a centralized repository of public health agencies and clinical data registries at the state, local, and national level, including their readiness. So that they said at the start of calendar year 2017 it would be available, and they also went as far as to say that if they're not on that registry by 6 months prior to the end of the calendar year, you can take an exclusion for that because you can assume that it's not ready. So you don't have to. You can't have somebody sneak in and say, "Well, I was there in 2017."
Kind of interesting. We have an REC on the REC listening, and she said, "I'm with an REC, and we are looking for answers too." Smiley face. So everybody's looking for.
Hi.
Everybody's looking for answers. We obviously did not get to all of our questions, either from people listening in live or from the registrants. So if we did not get to your question, again, please email me, Carol@HightechAnswers.com, Steve S. Spearman at HealthSecuritySolutions.com, and Beth Hogue at Beth at SA Ignite. Before we leave, Steve, I'm going to go back to your link. Please check out healthsecuritysolutions.teachable.com. Steve's got some free webinars, video conferences up there on some of these issues. Please contact Beth at SA Ignite and check out saignite.com. They are in the MU, PQRS, MIPS space big time, and they have a great FAQ about the MIPS program that you should check out for those of you who still have burning questions about MIPS, as we all do. If you do have burning questions about MIPS, please check out our monthly event on healthitanswers.net, as well as our next HIPAA chat. I hope that we get to do
Beth, I'm waiting for my invite, for the crossover event.
Well, I just want to say, hopefully we'll have another crossover event soon, because this
has to happen, Steve.
It has to happen. Because this was a whole lot of fun. Again, I will get the YouTube link out to everybody. Beth, thank you so much for joining us today and
thank you, Beth.
Sharing your knowledge, Beth.
You're so welcome. You're so welcome.
Yeah, and for all of you listening in, and it's Friday, have a good weekend.
That sounds great. Thank you, everybody.
Bye.
Have a great weekend.
Bye-bye.